Hello everyone. In this video on obstetrics series, today we will be talking about the various type of spontaneous abortion like threatened, inevitable, complete, incomplete, missed, and septic abortion, and we will be talking about their sign, symptom, investigation, management, and treatment of this all these abortion types. So firstly, discussing about the threatened miscarriage. As threatened miscarriage, it is a clinical entity where the process of miscarriage has started but has not progressed to a state uh, uh, from which recovery is impossible. In simple word, we can say that process of miscarriage has started but it is reversible. The recovery is possible and we can prevent the abortion. And the clinical, the patient having symptoms suggestive of this pregnancy, complaints of bleeding per vaginum. This is usually slight and may be brownish or bright red in color. On rare occasion, bleeding may be brisk, especially in second trimester. But the bleeding is usually stopped spontaneously, and the pain and the bleeding is usually painless, but sometimes there can be mild cramp, backache, or dull pain in the lower abdomen, and the pain usually follows after hemorrhage. First of all, bleeding occurs, then sometimes pain appear, but usually this threatened abortion is painless. And on the pelvic examinations, we should do it as gently as possible. And on speculum examination, perispeculum examination, it reveals the bleeding from the external os. If there is any bleeding, then it escapes from the external os. The differential diagnosis of this bleeding is includes ectopic pregnancy, and the molar pregnancy. And the digital examination contains digital examination reveals the closed external os. The external os is closed, and the uterine size, that is height of the fundus, correspond to the period of amenorrhea, or also known as period of gestation. Height of the fundus is equal to period of gestation. These are equal. Why this is equal? Because the fetus is still, the fetus hasn't come out, the abortus hasn't come out, it is already it is inside uterus, so that's why. And the uterus and cervix feel soft, uh, and with time the bleeding and pain subside and the pregnancy continues. And investigation, the routine investigation include the blood for hemoglobin, hematocrit, ABO, and RS grouping. The blood transfusion may require if abortion becomes inevitable. The anti-D gamma globulin has to be given for the RS negative non-immunized women. And the urine for the immunological test for pregnancy is not helpful, as the test remains positive for variable period even after the fetal death. So this is not helpful. I am crossing this. And uh, and we can do transvaginal sonography finding, and the transvaginal sonography helps to confirm pregnancy, its location, and the viability. The gestational sac is visible as early as 4 to 5 weeks of gestation. The yolk sac is seen at 5.5 weeks. The embryo is seen at around 6 weeks with presence of cardiac motion. With this, there is 98% chance of continuation of pregnancy. The embryonic sac is diagnosed when the mean gestational sac diameter is greater than or equal to 25 millimeter, and no embryo is seen on transvaginal sonography. It suggests early pregnancy failure. Thus, the serum progesterone value of greater than or equal to 25 nanogram per ml generally indicate a viable pregnancy in about 95% of the cases. The serial serum HCG level is helpful to assess the fetal well-being. The ectopic pregnancy must be ruled out during an investigation. And talking about treatment part, the treatment is the rest. The patient should be in the bed, pelvic rest for few days until bleeding stops. The prolonged restriction of activity has not got any therapeutic value. Only for few days the patient should be on rest. There is also evidence that the treatment with progesterone improves the outcome. Progesterone uh, Progesterone induces immunomodulation to shift the T helper 1 pro-inflammatory response to T helper 2 anti-inflammatory response, as we have already discussed about this TH1 and TH2 in the previous video in the etiology of abortion. So the TH2 is better for the successful pregnancy. And on the advice on discharge, she is to be followed up with the repeat sonography at 2 to 3 weeks of time. The unfavorable outcome is indicated by the falling serum beta HCG, decreasing size of fetus, irregular shape of gestational sac, or decreasing fetal heart rate. These suggest unfavorable outcome. And the prognosis is that in about 2/3 of the case the pregnancy continues beyond the 28 weeks of gestation, and in remaining 1/3 of the cases it ends either as inevitable or miscarriage. If the pregnancy continues, then there is increased risk of fetal of preterm labor, placenta previa, placental abruption, growth restriction, and fetal anomalies. So these have to be kept in mind. There is term known as inevitable miscarriage. Here the process of abortion has a stage from where that is not reversible. It is a clinical type where presence of bleeding, cervical dilation, and abdominal pain indicates impending abortion. That is so we will repeat it again. The process of abortion has reached a stage from where it is not reversible. So this is called inevitable miscarriage. And according to DC Dutta's definition of for this inevitable pregnancy, we have to write this definition in exam from DC Dutta. It is the clinical type where the presence of bleeding, cervical dilatation, and the abdominal pain indicates impending abortion. And the clinical feature of the inevitable abortion is the patient having the feature of threatened miscarriage develops the following manifestation: the increased vaginal bleeding, the aggravation of pain in the lower abdomen, which is colicky in nature. The internal examination reveals the dilated internal os of the cervix through which the product of conception are filled. And the poor abdominal examination shows that height of the fundus is equal to period of amenorrhea. So these are equal. Again, in threatened abortion also it was equal, and here in the inevitable miscarriage it is also equal, because the product of conception hasn't come out, so that's why they are equal. Height of the fundus is equal to this is a period of gestation. It is simple logic. And the management part is that the management is aimed at to accelerate the process of expulsion and to maintain the strict asepsis. We have to accelerate the process and to maintain the strict asepsis. The general measure include the excessive bleeding should be promptly controlled by administering methadone 0.2 milligram or oxytocin 10 international unit intramuscular if the cervix is dilated and the size of uterus is less than 24 weeks. The blood loss is corrected by IV infusion, IV fluid therapy, and blood transfusion. And the acute treatment and active treatment is done before 22 weeks. The dilatation and evacuation followed by curettage of the uterine cavity by blunt curette using analgesia or under general anesthesia is done. Dilatation and evacuation followed by curettage. And alternatively, suction evacuation followed by curettage can also be done. And after 12 weeks, the uterine contraction is accelerated by oxytocin drip, a 10 unit of oxytocin in 500 ml of normal saline, 40 to 60 drops per minute. And if the fetus is expelled and the placenta is retained, it is removed by ovum forceps. And if lying separated, if the placenta is not separated, the digital separation followed by its evacuation is to be done under general anesthesia. Now we will move on to the third type, that is complete miscarriage. In this miscarriage, the product of conception are expelled in masses. That is, entire process of miscarriage has been completed on its own. The clinical feature is that there is history of expulsion of fleshy mass per vaginum, followed by the subsidence of abdominal pain. There will be expulsion of the fleshy mass and the pain will subside. And the vaginal bleeding is very trace or absent. The internal examination reveals that the uterus is smaller than period of gestation. Why? Why? Because the product of conception has already come out. That's why uterus is less than POG. And it is little uterus is little firmer, and the cervical os is closed. The bleeding is very trace. The examination of expelled fleshy mount is found to be complete. If we examine the expelled the fleshy mass, and we can see that it is complete. And the transvaginal ultrasonography reveals that there is uterine cavity is empty, because already the miscarriage has been complete. That's why it shows the empty uterine cavity. And if it doesn't show the empty cavity, if there is something inside uterus, then we have to do the evacuation of the uterine cavity using the we have to do evacuation, and we have to do uterine curettage. And in RS negative women, the RS negative patient without any antibody in our system should be protected by anti-D gamma globulin. Anti-D gamma globulin 50 milligram or 100 milligram intramuscular. The 50 milligram is sorry, not milligram, 50 microgram is given in early miscarriage, whereas 100 microgram is given in late miscarriage within 72 hours after miscarriage. And however, anti-D may not be required in cases with complete miscarriage before 12 weeks of gestation where no instrumentation has been done. So we will see the picture. This is the inevitable miscarriage. This picture is an inevitable miscarriage. The process of abortion has reached a stage from where it is not reversible. So you look, the conception has already reached a very downward position, and we cannot avoid this abortion. It will take place anyways. Here the cervix has dilated and there is bleeding. So there is bleeding, cervix has dilated, and abdominal pain is there, and it indicates impending abortion. This is called as inevitable miscarriage. This picture shows complete miscarriage. Here the uterine cavity is empty. Now we will talk about incomplete miscarriage. It is the miscarriage where the entire product of conception is not expelled. Instead, a part of it is left inside the uterine cavity, and it is called incomplete miscarriage. And this is most common type made among the women hospitalized for miscarriage complication. And the clinical features include the history of expulsion of fleshy mass, just like missed, but here it is followed by continuation of pain in lower abdomen. What was present in the complete miscarriage? There was a expulsion of fleshy mass, but followed by subsidence. The pain has been subsided. But here, in the incomplete miscarriage, the pain is still persisting, followed by continuation of pain. The pain has not subsided in incomplete miscarriage. This is difference. And there is persistence of vaginal bleeding. The vaginal bleeding was absent in the complete. The internal examination reveals that the uterus is less than period of gestation, because again some part of the period of product of conception has already expelled out, and there is variable amount of bleeding. The internal os is open and the period of this conception is coming out. We can see that period of conception is coming out. And on examination, expelled mass is found to be incomplete. And in ultrasonography, we can see the heterogeneous echogenous material period of conception within the cavity. This figure is of the incomplete miscarriage. Here you can see that the product of conception is still inside the uterine cavity and it is not releasing. There has been bleeding, and so that as well. In the complete, there is a uterine cavity open in the complete miscarriage, but in the incomplete miscarriage, there is some part of the abortus is still inside the uterine cavity. The complication of missed pregnancy is that the retained product may cause profuse bleeding. It can cause sepsis and the placental polyp. Profuse bleeding, sepsis, and placental polyp. And the management is that In recent case, evacuation of the retained product of conception ERPC ERPC is to be done. She should be resuscitated before any active treatment is undertaken. In early abortion, dilatation and evacuation under analgesia or general anesthesia is to be given. The evacuation of uterus may be done using manual vacuum aspiration also. And the late abortion, the uterus is evacuated under general anesthesia and the product are removed by ovum forceps or by blunt curette. In the late cases, the dilatation and curettage operation is to be done to remove the bits of clot tissues left behind. The removed materials are subjected to histological examination. The medical management of the incomplete miscarriage may be done. The tablet misoprostol, 200 microgram is used vaginally every 4 hours, and compared to the surgical method, the complications are less with the medical method, and medical method can be done. And finally, we will talk about the missed miscarriage, and also known as early fetal demise. When the fetus is dead and retained inside the uterus for a variable period, it is called missed miscarriage or early fetal demise. The pathology is that the cause of prolonged retention of the dead fetus in the uterus are not clear. The liquor amni gets absorbed and the placenta becomes pale, thin, and maybe adherent. The ultrasonography diagnosis is the crown rump length is more than 7 mm with no cardiac motion is seen. The mean sac diameter is greater than 25 mm and no embryo is seen on embryonic sac. There is collapsing gestational sac, irregular amnion and yolk sac. Calcification indicates the embryonic demise. And the clinical feature are the feature of threatened miscarriage are there, followed by persistence of brownish vaginal discharge and sustenance of pregnancy. What were the feature of threatened miscarriage? That is the bleeding per vaginum. There will be bleeding per vaginum followed by persistent of brownish vaginal discharge and the sustenance of pregnancy symptom. And on examination, we can see that there is absence of fetal ultrasound with Doppler ultrasound. The real-time ultrasonography reveals the absence of fetal cardiac motion and the fetal movement. The management, before management, let's talk about complication. The complication of the missed miscarriage is same that of intrauterine fetal death, and we'll be talking there in detail in the videos about intrauterine fetal death. So, in the management of missed miscarriage, uterus is less than 12 weeks. In the patient with less than 12 weeks uterus, we can do expectant management. The woman may expel the conception spontaneously. We will wait and watch. The medical management includes the prostaglandin E1, that is known as misoprostol 800 microgram vaginally in the posterior fornix is given and repeated after 24 hours if needed. Expulsion usually occurs within 48 hours. Also, the suction evacuation or dilatation and evacuation is done either as a definitive treatment or it can be done when the medical method fails. The risk of damage to the uterine walls and the brisk hemorrhage during the operation should be kept in mind if we follow the suction evacuation method. A medical method includes the misoprostol 800 microgram vaginally. In the woman with uterus more than 12 weeks, the induction of abortion is done by the following method. And the prostaglandin are more effective than oxytocin in such case, and method used are the combined regimen of 200 milligram mifepristone, 200 milligram mifepristone orally, followed by 800 microgram misoprostol through any route, buccal, vaginal, or sublingual is effective. The alternate regimen is 800 microgram of prostaglandin E1 analog, that is misoprostol tablet, used in any route, buccal, vaginal, or sublingual. And secondly, we can use oxytocin, 10 to 20 unit of oxytocin in 500 ml and normal saline with 30 drops per minute is started. If false scalding dose of oxytocin to a maximum of 200 unit may be used with monitoring. The following medical treatment, the ultrasonography should be done to document empty uterine cavity. Otherwise, the evacuation of the retained product of conception should be done. The ultrasound done and then ESPC done. Evacuation of retained products of conception. And the dilatation and evacuation is done once the cervix becomes soft with the use of prostaglandin E1. Otherwise, cervical canal is dilated using the mechanical dilator or by laminaria tent. Evacuation of the uterine cavity is done thereafter slowly. So that was about missed abortion, missed miscarriage. So in this next video we will talk about septic abortion. Till then, goodbye and keep revising. Thank you.